In this video, we will be discussing about the next symptom in neurology, that is dementia. Dementia is another symptom or another presentation with which the patient presents to the emergency or in the OPD. Uh, Dementia is basically defined as an acquired deterioration. The word very important here is acquired. Acquired deterioration in cognitive abilities, right? That impairs the successful performance of activities of daily living. We spend our daily lives with the help of cognition. We do our daily work, daily course with the help of our cognition. What comes in our cognition is memory, intelligence, speech, judgment, behavior, mood, and problem solving, praxis, visuospatial abilities. So these all are the domains of cognition, and when cognitive abilities they deteriorate and they are basically acquired in nature, that is the definition of dementia. Dementia not only is restricted to the loss of memory or impairment in memory, but all the other cognitive domains are involved, although in most classical example of dementia, that is Alzheimer's disease, uh, the most commonly affected domain is dementia. So is memory. So whenever dementia comes into our mind, the picture that comes into our mind at that time is loss of memory. But remember, dementia is much more than loss of memory. So loss of cognitive symptoms is there. What cognitive symptoms? Most common is episodic memory. It is most common in Alzheimer's disease, and Alzheimer's disease is the most common cause of dementia. Then language may be impaired, visuospatial skills, praxis, calculation, judgment, and there can be some neuropsychiatric manifestations like depression and anxiety. Depression and anxiety are are often present along with loss of memory and other loss of other domains. So this is the basic understanding or basic definition of dementia. Now coming on to the next slides, we will be discussing the functional anatomy of dementia, that what structure in the brain is impaired or is damaged which leads to dementia. See, dementia is basically the higher functions are involved, and higher function, there is no certain set of, there is no certain area or no particular area that okay, this area is responsible for memory or intelligence or speech, but there are circuits, there are major circuits which are responsible for maintaining the cognitive abilities. And remember, all these circuits they originate from the prefrontal cortex, right? So these are the connections which connect the cortical areas to the subcortical areas, to different lobes. Prefrontal cortex is connected to temporal lobe, prefrontal cortex is connected to subcortical, other subcortical areas, hippocampus, entorhinal cortex, etc. So these are the, we don't need not go into the details of the structures that what is happening in there, but at least we must know that what are basic areas, basic connections, or the basic two, three, four areas which are connected in order to make a circuit which is responsible for maintaining the cognition. So we will be coming on to that, but first of all we must understand that what happens in different kinds of dementia. In Alzheimer's disease, what is involved? Entorhinal cortex is involved most of the times. I mean, it is the first area to be involved, right? Then it will go into the basal temporal lobe, then to the lateral lobe, and then so on and so forth to the parietal lobe, to the frontal lobe also. So to begin with, Alzheimer disease starts in entorhinal cortex. It is very important, it is asked in many exams. So entorhinal cortex is responsible for Alzheimer's disease. Vascular dementia. In vascular dementia, the areas involved are, maybe cortical areas are involved, maybe subcortical areas are involved. But important point is that cortical subcortical areas are involved, but they are focal. There is no diffuse damage, right? The small vessel, wherever the small vessels are involved, first they will be involved, they will be damaged first, there will be infarction, there will be lacunae in that area. So in vascular dementia, cortical subcortical areas are involved, and there is focal damage. There is no diffuse damage, but focal damage. This is vascular dementia. Frontotemporal dementia and Huntington disease. In both these causes of dementia, the most commonly involved areas are the cortical areas, followed by subcortical areas. Right. So this is the areas which are involved in these dementias. Now, what are the actual circuits which are involved? There is loss of frontostriatal pathways, right? There is frontal to the striatum. Striatum involves putamen, striatum involves the neocortex, etc. Right? So, striatum is caudate, putamen, nucleus accumbens. These are involved. Frontal means these are the circuits which start from the frontal lobe to the striatum, and there can be many. There can be dorsolateral prefrontal cortex, which is connected to the caudate nucleus by one circuit. Then there can be dorsolateral prefrontal cortex. There can be, lateral orbital frontal cortex. There can be anterior cingulate cortex, which is connected to the nucleus accumbens. So we need not go into the detail, but we must understand that there are 3 4 circuits, not areas, but circuits, which are there. And when for example frontal lobe is involved, these circuits will be damaged, right? These circuits will be damaged, and they will cause a certain dysfunction, and that certain dysfunction will be in some of the cognitive domains, and it will eventually lead to dementia. This is the anatomical explanation of dementia. So coming on to the next slide, what are the causes of dementia? I have divided, there is a very huge table in Harrison's, but I have picked up the important points, and I have divided those points into few causes, like most common causes, and few causes which are less common causes. We must remember the most common cause of dementia is Alzheimer's disease. It is the most common cause. Then comes the vascular dementia, then comes alcoholism, then comes Parkinson disease with dementia, and Lewy body dementia. This is a basically spectrum. If motor symptoms are present initially, it is Parkinson disease with dementia. If motor symptoms are present late, it is Lewy body disease or Lewy body dementia spectrum. So these are the four most common causes that you must not forget. Then there are a few less common causes, like vitamin deficiencies. Vitamin B12 deficiency may be there, right? It can cause dementia. Then endocrine causes like hypothyroidism or Addison disease. These causes can also cause dementia. Chronic infections, Lyme's disease, right? Lyme's or HIV. HIV causes hand neurological uh, disorder. Head trauma can also cause dementia. Then there are certain degenerative disorders which are causes of dementia, like multiple system atrophy, Parkinson disease, even Alzheimer's disease comes under this. Alzheimer's disease with Down syndrome. Remember, when Alzheimer's disease is associated with Down syndrome, it presents early in 40s. Otherwise, in classical Alzheimer's disease, it presents late in the 7th or 8th decade. Then there can be other causes like Creutzfeldt-Jakob disease, etc. So these are the degenerative disorders. Others are like Huntington's disease, frontotemporal dementia, right? And Lewy body dementia, even Parkinson disease with dementia. They all come under neurodegenerative disorders. Mitochondrial disorders can also cause dementia. So the list is long, but we have to remember the important ones. Most common Alzheimer's, less common may vitamin deficiencies, endocrine causes, and some degenerative disorders. Like these are the causes of dementia. Now, how do you approach to the patient with dementia? Remember, we are studying about the symptomatology. That is, we are trying to understand the dementia as a symptom. When the patient comes to you in the OPD, how do you recognize that this is dementia and not delirium and not something else? So we will go step by step. Of course, when patient comes to you, how do you start examining the how do you start interrogating the patient? You first of all you take history, then you do physical examination, then you do investigations. History, in history the patient presents to you with a complaint. What will be the chief complaint of the patient? The patient may tell that he is having some memory problem. He is not able to recall his past moments like episodic memory, means important episodes of life are gone from his mind, like when he was married, when he was born, when he cleared an exam, when he got his job, right? uh, when is the birthday of his children, what is the name of his children. So he may forget, he may lose these important events in his memory. This is called as episodic memory. Patient may come with these complaints, or the attendants of the patients, they may complain about his behavior, they may complain about his uh, behavior, they may complain about his language, that he is not able to speak properly, he is mute all the time. Then his problem solving, his daily activities, his daily living is impaired, right? So these will be complaints that will be told by the attendants of the patient. So how is the onset? Onset can be acute onset. They will say that he has deteriorated in a few days or in a few weeks, right? The onset can be chronic. It can be a chronic, long lasting, right? So if there is an acute cause, you must rule out the delirium and Creutzfeldt-Jakob disease. These are the two causes of acute dementia. If chronic, it is Alzheimer's disease, right? Progression, if it progresses, it is neurodegenerative in nature. Neurodegenerative like Alzheimer's disease, frontotemporal dementia, uh, Parkinson disease with dementia, means they are progressive. If it is non-progressive, it can be vascular. Vascular is usually non-progressive. Associated factors, what are the associated factors? Whether the patient had a history of head injury, whether the patient has movement disorders, along with the complaint of dementia. We have to rule out these things also. Is the patient having any difficulty with gait? It will be occurring in normal pressure hydrocephalus. Movement disorder will be occurring in Parkinson disease with dementia or Huntington's disease. Head injury will be associated with dementia, and it will be associated with chronic headache. So these are the associated factors that we have to take into consideration. These are the important points that we have to ask the patient or the attendants in history. Then physical examination. In physical examination, there is nothing much to understand, but yes, ultimately physical examination may reveal some autonomic dysfunction. Autonomic dysfunction in physical examination is seen in Autonomic dysfunction is seen in multiple system atrophy. So these are few hints that you will get out of the physical examination. Important is neurological examination. In neurological examination, you will ask the patient about you will examine the motor part of motor part. Means if there are tremors, if there is rigidity, like axial rigidity, and no motor involvement may also be there, but profound dementia. If there is no motor involvement but profound dementia, it points towards the Alzheimer's disease. If there is tremors, it will point towards Parkinson disease with dementia or frontotemporal dementia. Sorry, Lewy body disease. If it is rigidity, it points towards frontotemporal dementia. If there is dystonia, it will point towards Huntington disease. So these are the important points in neurological examination. Now you have to do the psychiatric examination also, because you have to rule out mild cognitive impairment, and it can be ruled out on the basis of two scores. One is MoCA and other is MMSE. MMSE. In MMSE there are five domains, right? Orientation, speech, registration, recall, memory, all these. So if there is score is less than 24, it means there is some dementia, some memory loss, right? So MMSE and MoCA are important in examining the patient of dementia, as they will unmask the underlying cognitive impairment. In lab test you can do, always you can do MRI. What you will see in MRI, you may see temporal degeneration or temporal atrophy. You may see cortical atrophy. You may see lacunar infarcts, right? Temporal, cortical, lacunar infarcts. Then there can be PET scan to rule out for tau and A beta amyloid. It will be seen in Alzheimer's disease. Lumbar puncture is not done routinely, but you will see elevated level of A beta 42 in CSF in Alzheimer's disease. Lacunar infarcts are seen in vascular dementia. Cortical atrophy is seen in frontotemporal degeneration. I mean frontal cortical atrophy. Temporal atrophy is seen in Alzheimer's disease. In normal pressure hydrocephalus, you will see dilated ventricles, right? In vascular dementia, you may also see subcortical white matter hyperintensities or subcortical diffuse white matter changes. These are the findings that you will see on MRI. How will you treat the patient of dementia? We have to treat the reversible causes like vitamin deficiencies and infections. Vitamin deficiency like vitamin B12, infections like HIV or Lyme's disease. If there are behavioral problems like agitation and inappropriate behavior, disinhibition, you can always give benzodiazepines. If there is memory problem, you can give acetylcholinesterase inhibitors like rivastigmine, donepezil. If there is depression, you may give SSRI along with that. So these are the treatment options that we have in a case of dementia. Now we will be looking into some important pictures that are given in Harrison's. This picture here shows us that there is temporal degeneration. You may compare it with here. Here the temporal lobe is very good, right? And how do you see it here? Here the temporal lobe is degenerated. Here it is very much good. Here it is degenerated. The temporal lobe is lost in Alzheimer's disease, right? It is the PET scan which shows reduced uptake or very low uptake of amyloid or tau proteins. Here you can see increased uptake of amyloid. It is deposited in the frontal regions, in the temporal regions. This is also suggestive of Alzheimer's disease. Uh, what is B? Okay, this is also Alzheimer's disease, in which it is the normal cortex. Here is the cortical atrophy. You can see the more marked grooves, the more finger-like projections. These are the the atrophied cortex. Here you will see diffuse white matter disease. The white matter here is very much increased, very much diseased type. It is fibrous type. It is seen in vascular dementia. All right. Now here is the normal pressure hydrocephalus. You can see the dilated ventricles, right? Normal pressure hydrocephalus will present with gait ataxia, urinary retention, and dementia. These are the findings in MRI in normal pressure hydrocephalus. Now, okay, that is all about the dementia. I have taken the reference from Harrison itself. Now, if you go back and read Harrison, it will be very much easier for you. I hope you have learned something valuable from this video. I will be seeing you in the next video.